think we are ready to start. All right. Hello, everyone. Thank you for joining us today. My name is Ertaka Lanji. I'm a researcher at CDEP, and I'll be moderating the webinar for today. This is the third webinar in our Conversations series in Global Health, which we have launched to celebrate our 10-year anniversary. Today's webinar has been organized in collaboration with the World Health Organization, as well as the support of the speakers that have joined us today. Today's discussion will explore the critical interplay between vaccines and antimicrobial resistance. And in order to get a comprehensive picture on this issue, we have experts from different fields of research and policymaking here with us today. We are honored to have with us today Dr. Hanan Balkhy, Assistant Director General for Antimicrobial Resistance at the World Health Organization. We have Dr. Deepali Patil, Acting Head of Policy at Gavi. We have Dr. Padmini Srikantiah, a Senior Program Officer and AMR Strategy Lead at Bill and Melinda Gates Foundation. We have Dr. Mateusz Hasso, a Technical Officer at the World Health Organization, and Dr. Joseph Lewnard, Assistant Professor at UC Berkeley. Now, we will start the discussion today with a brief introduction to this topic by the Director of CDEP, Dr. Ramanan Lakshminarayan. So thank you for joining us today, and over to you, Ramanan.
Thank you, Urta, and thank you all for being here. It's exciting to celebrate CDEP's 10th anniversary this way. Now, AMR, as you know, is a topic that's very close to the work that CDEP does. And particularly the area of vaccines is one which hasn't received as much attention until recent times. We know anecdotally and obviously from published evidence that, for instance, the introduction of the pneumococcal vaccine in many countries has been instrumental in reducing childhood antibiotic use. In fact, in the US, where it has been measured quite well, the introduction of the 7-valent vaccine in around 2000 was instrumental in both reducing pneumococcal strains that were sensitive to antibiotics, but also ones that were resistant to antibiotics. Now, we haven't had much evidence on the role of vaccines on AMR apart from the pneumococcal vaccine. And in a project that was supported by the Gates Foundation and in a partnership with the World Health Organization and also the Wellcome Trust, we had done some work to look at what the effect would be of introducing vaccines or scaling up vaccines for rotavirus, for Shigella, for tuberculosis. Obviously, in some cases, the vaccines exist and need to be scaled up. In other instances, the vaccines don't really exist, and they deserve to be produced. And we've done this across a range of diseases. I think you'll hear that from some of the speakers today. But what's interesting is that this also comes at a time when global support for vaccines is very high thanks to COVID. So people are aware of vaccines and have a lot of respect for what vaccines can do. There's also a need for this kind of evidence to inform the kinds of vaccines that will be supported in national programs and also financially by entities like Gavi to make sure that the value of the vaccines in reducing AMR is recognized as part of that vaccine introduction decision. So that's really the focus of our discussion today on how vaccines can address AMR. And as we all know, behavior change is one of the major ways in which we try to deal with AMR, with reducing the use of antibiotics. But if we can reduce the need for antibiotics by using vaccines and also reduce the prevalence of resistant infections by using vaccines. These are the two mechanisms that you'll hear from our first speaker, Joe Lewnard. Then we can go a long way in using vaccines as being a primary tool in addressing AMR. And what I'd love to hear from the speakers and what I'm most curious about is, can the improvements in vaccinology that have happened over the last decade or so and which continue to accelerate with investments in COVID vaccines, could they help us solve a large part of the AMR problem with vaccines? Obviously, we'll have to do infection control and we'll have to do water and sanitation, all the other things. But could vaccines help us take a big bite out of this problem as it has helped us in many other issues? So with that, I'll hand back to Urta. And again, welcome and thank you all for being here.
Thank you, Ramanan. It's our pleasure to have here today Dr. Balkhy, who is going to share with us the World Health Organization perspective on vaccines and AMR. So thank you for joining us, Dr. Balkhy. Over to you.
Thank you, Erta, and good evening, good afternoon, good morning to everybody, and good afternoon from Geneva. Thank you for inviting me to be part of this very exciting event, and congratulations to CDEP and Ramanan and all your leadership and partners in your organization for 10 years and for doing some really amazing work that has opened the world's eyes on major burden of AMR. So thank you for all the work that you do. As you probably know, that the COVID pandemic has created an unprecedented collaboration among the global players in health, economics, politics, and in many, many areas that we have never fathomed. I've never thought that we would even live such a pandemic, that even for me, for the past 20 years, I kept preaching about the next pandemic and we need to be prepared and aware, but I don't think that, I never thought that we would actually live through it. And I think that the viral infections, such as Ebola, the viral hemorrhagic ones, the novel influenza, the coronaviruses, they're lucky enough to get enough attention. What we're facing with the MDROs and with the gram-negatives and bacterial and AMR is that they will never, in my humble opinion, reach the attention that some of these other viruses have reached. And the evidence to that is that we've been facing and dealing with one emerging pathogen after the other, and then we become, which I like to say, a bit numb or used to having that pathogen lurking around in our institutions and in organizations. So with the WHO paying a lot of attention to this in 2019, the AMR division was established to enhance the collaboration and communication among the different entities that deal with AMR. And this unit, specifically the vaccine unit within the WHO, is one of the extremely relevant pillars of the 2015 AMR Global Action Plan that was released by the WHO, which is the major roadmap or assistance for the member states to develop their AMR national action plans. And I think coming here today to discuss specifically vaccines is extremely important. Again, the COVID pandemic might help us enhance and give better attention to adult vaccine programs, which the Global Action Plan for AMR talks about, but really does not have that strong of a political stick to make sure that countries do implement adult vaccine programs. I think the COVID might be our way into that. Also enhancing many of the EPI programs for children. We still have a lot of work in dealing with the anti-vaxxers and the doubters on that. That's a lot of work. And as Ramanan was saying, it's the behavioral attitude towards vaccines. But what I would like to emphasize today, there's so much to talk about what WHO has done in 2020. We launched our newsletter earlier this quarter, if you want to take a closer look at what we've been doing. We've tried to establish we're successful with one of the 3 global governance mechanisms with the establishment of the Global Leaders Group to provide better political enhancement for AMR in general. But what the vaccine unit has done is they have published the action framework for vaccines against AMR, and it focuses on 3 very common sense issues that need to be done. Number 1 is that it calls for making sure that we expand the usage, license, and accessibility to the vaccines that already exist, such as influenza, pneumococcal, and many of the other vaccines. And the vaccines that are not just respiratory, but the ones that actually, all of the vaccines that reduce the burden of infections, so the need for antibiotics goes down. The second one is to work more on the R&D and establishing more of the vaccine development for some of the vaccines that might be endemic in hospitals. We're going to figure out how do we need to use them, how can we use them. And the third one is trying to be innovative in R&D and modeling to try to understand the benefit of vaccines in driving AMR down. And I think the last one is extremely critical, and it can maybe be one of the first things that needs to be done so we can convince our partners, politicians, economists on what is the value of vaccinating populations when it comes to the cost to health and also the cost to antimicrobial use and the side effects that we also don't talk enough about, and as well as reducing the drive to more and more multi-drug resistant pathogens. So there's a lot to talk about for AMR, but I'd like to stop here and say that this is an excellent event. And I'd like to thank my colleague from the WHO, Dr. Mateusz, for engaging me also on this event. And back to you, Erta.
Thank you, Hanan. Thank you very much. We're now going to direct some questions to our speakers to get different perspectives on this issue. And we'll start with that from research. So Dr. Joseph Lewnard is here with us today, and we have some questions. Yes, so what does the evidence suggest on the impact of vaccines on resistant infections and antibiotic consumption?
Thank you for this. I'm going to share my screen to walk through a few slides going through recent studies of this nature in various pathogens and for various vaccines. So bear with me for a second while I open this. The question of how vaccination might impact both antibiotic use and ultimately the burden of resistant disease is a complex one, which I think can be tackled from multiple angles, some of which were nicely laid out in a recent, or now several years old, review article by colleagues Katie Atkins, Mark Jitt, and others at the London School of Hygiene and Tropical Medicine. Broadly speaking, the effects of vaccines might comprise several things that result from directly preventing infection or carriage of an organism. If that is an organism that is resistant to disease, then obviously that is resistant to drug treatment, then preventing disease involving that resistant organism is a very immediate benefit of a vaccine. However, other considerations might include that there is a reduced risk of disease that would trigger antibiotic use and therefore resistance selection when we use a vaccine to prevent infections involving a particular organism. We also reduce exposure of that pathogen to selective pressure from drug treatment when we prevent it from causing infection in a host. So this is another kind of broad benefit of vaccination beyond just preventing drug-resistant infections to begin with. And then maybe at a sort of higher level or in a more societal or clinical practice level, we might also consider how preventing infections involving particular organisms might impact the behavior of clinicians or the behavior of patients. For instance, if we can change the fundamental etiology of conditions that are common causes of antibiotic use, there might be less sort of justification for antibiotic treatment for particular common conditions that right now account for a whole lot of the outpatient antibiotic exposure, for instance, that happens in general clinical practice. One of the challenges that we encounter is that to date, not all of these effects have been all that well measured or all that well quantified, although with increasing attention to the subject, this is rapidly changing and emerging evidence suggests substantial effects of vaccines or potential effects of vaccines in several scenarios or for several pathogens. So one of the studies that we've worked on here in recent years on this topic was addressing antibiotic treatment for the two most common conditions among children that result in antibiotic treatment, which is acute respiratory infections and diarrhea. And so in this work, focusing on low and middle income countries globally, we used data to quantify the direct effects of pneumococcal conjugate vaccines and rotavirus vaccines shortly after they were implemented in various low and middle income countries in a large case control study to look at their effect on antibiotic-treated acute respiratory infection and diarrhea endpoints. And what we can see here is that in particular, at ages of roughly 24 to 59 months, we can see an almost 20% effect of pneumococcal conjugate vaccines in preventing antibiotic-treated acute respiratory infections. And similarly, in particular in the first 2 years of life when rotavirus is a very common cause of diarrhea, we can see a roughly 10% effect of rotavirus vaccines in preventing antibiotic-treated diarrhea episodes. And so this, I think, was sort of an important endpoint to quantify. We have always, evaluated and licensed vaccines predominantly on their effects on severe disease involving a particular pathogen, but knowing that vaccines such as these can have a fairly large effect beyond what we can achieve through, antimicrobial stewardship alone in preventing antibiotic use is an encouraging additional sign of their potential public health benefit. This view also gives us a sense of just how much antibiotic use is caused by some of these vaccine preventable pathogens. So having probed the amount of antibiotic-treated illness that's prevented by these two vaccines, we can see that just over 20% of both antibiotic-treated acute respiratory infections and just over 20% of antibiotic-treated diarrhea infections in children in low and middle income countries were attributable to vaccine-targeted Streptococcus pneumoniae and rotavirus. So just, another measure that's worth considering as we talk about which vaccines merit consideration for their potential effects on antibiotic use and antibiotic resistance is what is the etiology of infections that are ultimately receiving antibiotic treatment. This is especially interesting consideration for rotavirus because in its own right, rotavirus does not merit antibiotic treatment. It is a viral infection. However, treatment of diarrhea in the community, in particular in low and middle income countries, is common. And so a lot of the resistance selection that this exposes pathogens to could potentially be preventable and is being prevented by rotavirus vaccination. So for what other vaccines or for what other pathogens might this be a worthwhile consideration? We looked, in addition to the study I just showed, also at revisited etiologic studies of diarrhea in the community and looking at the subset of cases that were antibiotic treated in low and middle income countries. We were able to quantify attributable fractions of diarrhea cases that were antibiotic treated associated with various pathogens. And so we can see rotavirus individually was in fact the leading etiology of antibiotic treated diarrhea cases, again underscoring the benefits of rotavirus vaccines for reducing antibiotic consumption. But then the next several pathogens down the list have some important lessons for us as well. So Shigella, of course, is another very prominent cause of severe diarrhea, potentially associated with very adverse clinical outcomes and the rapidly growing burden of resistance in Shigella, including multi-drug resistance and potentially in not too distant future untreatable infections, absolutely warrants consideration of vaccines against this pathogen. However, others that come high up on this list in terms of their attributable fraction in low and middle income countries were surprises. For instance, adenovirus and sapovirus are not necessarily infections that are associated with the greatest burden of fatal or very severe diarrhea cases. However, because they are common causes of diarrhea, they are in fact associated with a substantial proportion of all of the antibiotic treated diarrhea episodes. So, for pathogens like this that have not necessarily always been prioritized at the top of the list for vaccine development because they're not causing fatal disease, there might be substantial impact of vaccines that result in significant effects on antibiotic treatment of common conditions like diarrhea. Similar arguments to this have been raised, for instance, for streptococcal pharyngitis, since in the case of acute respiratory infections and pharyngitis in particular, this is a very common cause of antibiotic treatment, and changing the etiology of a condition might reduce the clinical justification or patient expectations for antibiotic treatment. We can also look at least in several instances at instances where reductions have been achieved in resistant disease or in the proportion of circulating lineages that are resistant for a particular pathogen. So in recent work in Streptococcus pneumoniae, looking at changes in antimicrobial resistance globally following introduction of pneumococcal conjugate vaccines, for instance, we were able to see reductions in most drugs, including importantly penicillin, which remains the first line treatment for pneumonia in children globally. And we were able to see reductions here in both the proportion of isolates that were non-susceptible to antibiotics and fully resistant and potentially associated with treatment failure. In macrolides, this was a little bit less clear, which is of concern as macrolide use grows around the world. However, for other drugs, including trimethoprim and third-generation cephalosporins, which are a sort of second-line recommended treatment for pneumonia in low and middle-income countries for children, we were able to see clear reductions in resistance that have, in this instance, real meaning for preventing treatment failure and ensuring that children who receive antibiotics appropriately for pneumonia have a better chance at survival. Another interesting line of work has surrounded what the future might hold for tuberculosis vaccines. And as many on this call will know, in recent years, data have been published from clinical trials demonstrating considerable efficacy of anti-tuberculosis vaccines given post-exposure to prevent progression to active disease. And so recent work by colleagues Helen Fu and Nim Pathy at Imperial College London showed additional reductions that could be achieved through a vaccine with this kind of efficacy profile in reducing the burden of resistant tuberculosis cases relative to both status quo continuation of what's going on right now in terms of treatment and management of TB infections, but also as an additional strategy to reduce disease burden in conjunction with and sort of supplemental to improvements in the management of tuberculosis infections using the tools that we currently have to reduce the burden of resistant disease. And what we can see here, looking at the sort of dark red areas on these plots, is that this could be a substantial improvement for many different countries that are listed on the kind of x-axis here, beyond what we currently have at our disposal for ways of containing the burden of resistant disease. So I will stop my screen share there and go back to the panel for questions.
Thank you, Joe, for that very nice presentation and very thorough examples. What do you see as challenges when it comes to, what do you see as data challenges when it comes to addressing these questions at a large scale?
I think at a large scale, one of the fundamental challenges that we have is that we have done very little research maybe on the non-severe spectrum of disease that accounts for the greatest burden of antibiotic use, or the greatest fraction of antibiotic use. While we, for good reason, focus a whole lot on very severe disease and on the effects of vaccines against very severe disease endpoints, for instance, for pneumococcal vaccines, most trials have looked at prevention of invasive infections. For rotavirus vaccines, trials have looked at the prevention of very severe rotavirus gastroenteritis. While we have good understanding of vaccine impacts on these endpoints, we don't have as good of an understanding of just what pathogens out there in the community are accounting for the less severe disease cases that are very prevalent, very common causes of antibiotic use. And so if we want to achieve, reductions in antibiotic use, including through vaccination or other strategies that are really targeted to particular pathogens, we're kind of working from very little previous evidence on identifying what pathogens should be prevented and what the efficacy profile of vaccines might be on very non-severe or even non-specific outcomes, such as, acute respiratory infection or diarrhea of lower severity.
Thank you very much for that. Okay, so we'll move along with our next speaker, Dr. Padmini Srikantiah, and we have some questions. The Gates Foundation has been a strong advocate of vaccines as a key way to address child mortality. how are you starting to think about vaccines in the context of AMR?
Well, thanks, Erda, for the question, and thanks to the organizers for inviting me to join the panel. Congratulations to CDEP for 10 years of work, advocacy, and research. And it's great to have an entire webinar that is solely devoted to vaccines and AMR. You're right that the foundation has been working on vaccines, and vaccines form a central pillar of what the foundation does in terms of focus on prevention of infectious diseases and related deaths. In fact, I would say that in our AMR strategy, vaccines are really at the center of it. The prevention of infectious diseases and related deaths are the center of our overall global health strategy and form the basis of our antimicrobial resistance strategy. I think we heard some really nice examples of what vaccines can do for both antimicrobial resistance and antibiotic use from Joe. And in our work, even over the last several years, much of the work that we've been focusing on in terms of increasing vaccine rollout and vaccine use, whether it is with pneumococcus, which has actually, as Ramanan pointed out very early on, has actually made a significant impact in not only antibiotic use for invasive pneumococcal disease, but actually reduction in resistant strains. Or for other pathogens, like more recently typhoid, where the typhoid conjugate vaccine actually gained WHO pre-qualification with a specific indication and a prompt because of rising multi-drug resistant strains in South and Southeast Asia and other parts of the world. And our enteric and diarrheal diseases team, our pneumonia team, and other global health teams have been focusing on ensuring that these vaccines are scaled up, rolled out, delivered to the communities that need them, both with both impacts: reduction in disease, reduction in related deaths as the most central, but also reduction in resistant strains for pneumococcus and typhoid, and the potential of reduction in antibiotic use that we have seen in some and increasing data and a data need that we hope that groups like CDEP and WHO continue to address. Regards to our antimicrobial resistance strategy, we have now taken that approach and applied it also to some of these WHO priority pathogens, but also looked beyond just WHO priority bacterial pathogens to include, what are the impacts of vaccines on additional pathogens, including viral pathogens, where, as Joe pointed out, there may not be a role for antibiotic use directly, but the addition of a vaccine to prevent a viral illness can make a clear impact on antibiotic use for that syndrome. One of the examples that Joe mentioned was rotavirus. Ramanan mentioned influenza, which I think is probably the most striking example for which there have been a lot of data for a number of years. There's a great paper from, I want to say, about 12, 13 years ago now from Ontario, where seasonal influenza vaccination was actually free and given to the entire province in over a given year. And they compared antibiotic use in that province to other provinces in Canada. And there was approximately 60–65% reduction in antibiotic use just in this observational study. So you can imagine that there's great promise. One of the other pathogens which is a clear priority for the pneumonia team at the Gates Foundation, which is a virus, is respiratory syncytial virus, or RSV, which is a major cause of pneumonia in young infants. And there have been a few different papers recently that show that not only would a RSV vaccine have impact on RSV disease in young infants and related deaths, but also may have impact on preventing future episodes of lower respiratory tract infections, as well as the incumbent antibiotic use. Within the AMR strategy, our priority focus is on neonatal sepsis, which we believe this population is at greatest risk for poor outcomes and death related to antimicrobial resistance in these WHO priority pathogens. So, vaccines has always been a central part of our work in global health at the foundation, and now it forms the central pillar of our AMR strategy as well.
Thank you for that. You just touched upon the priority areas, but would you like to add something more specifically on what those areas would be?
So I think actually in terms of antimicrobial resistance, we are most concerned about the potential excess mortality that would be borne by the most vulnerable populations. These are particularly in low middle income countries. Surveillance work that the foundation has supported over the last several years suggests that that neonatal sepsis or invasive bloodstream infections in neonates in the first month of life are increasingly caused by gram-negative organisms that are multi-drug resistant, as well as sometimes also Staph aureus is a gram-positive organism. Again, methicillin-resistant Staph aureus plays an important role. Far and away, the most common pathogen and most important pathogen that we see across multiple geographies that is time and again a leading etiology of neonatal sepsis in low middle income country settings is Klebsiella pneumoniae, which as Hanan referred to earlier, Klebsiella and these other MDR organisms are central to WHO priority pathogens and priority pathogens for CDC and as well as other organizations. In Klebsiella, the data that we have supported to generate, we see that actually Klebsiella is an important pathogen that is in the causal chain of neonatal deaths or neonatal infectious deaths in approximately 30 to 40% of neonatal infectious deaths across multiple geographies. And this is from data that have been generated from the Child Health and Mortality Prevention Surveillance Platform, or CHAMPS platform, along with other platforms, including that a very important and multi-country study done by a neonatal observational cohort study by GARD-P. So our focus now is actually on the development of for Klebsiella, particularly a development of a Klebsiella maternal vaccine. We're at the very early stages of this. There is, as Hanan also suggested, a potential for a dual market because Klebsiella, as folks probably know, is a very important nosocomial pathogen for adult populations in multiple countries, both in low and high middle income country settings. So in the situation of neonates, we believe that the development of a maternal vaccine given to pregnant women in their third trimester of pregnancy that could generate protective antibodies or conceptually would generate protective antibodies to the responsible Klebsiella strains that are causing sepsis and death would then be passively transferred to the infant over the placenta, and that infant would be protected in that most vulnerable period of time. So we hope that with, and this is as I mentioned, something that we're at the very early stages of, and a pathway that we're embarking on now. But we do believe that this vaccine approach will have relevance certainly for Klebsiella, for neonates, and potentially for other populations as well.
Thank you. Thank you so much. Thank you so much for your insights. And we're now going to go back to the World Health Organization perspective. And we have here Mateusz Hasso today. So could you please elaborate a bit on the World Health Organization strategy on how to understand, articulate, and communicate the value of vaccines against AMR?
Great. Thank you so much, Erta, for the question, and thanks to Ramanan, and congratulations to CDEP for organizing this great webinar. You know, over the past few years, we are seeing more and more focus on vaccines and antimicrobial resistance, so it's really nice to see and be able to participate in such an event. And also would like to extend my thanks to Hanan for describing the environment of AMR and that is taking place at WHO. I'm hoping that maybe I will be able to give you a bit more practical perspective as to what is it that we're doing in terms of work streams, who is it that we are engaging with, and what is it that we are trying to achieve in the immunization department at WHO. I think that our work has started a few years ago when there was a clear need from a number of experts, even experts in the vaccine and AMR field, that the role of vaccines against antimicrobial resistance has not really been very well understood and articulated and communicated, whether it's within the experts or even to the outside community. And I think there was a call for WHO that, yes, this is something that you should probably take an active role in to fulfill these activities and think of it in a strategic way. But I think before we embarked on this journey, we sort of ask ourselves, why do we actually need to understand this role of vaccine against antimicrobial resistance? And I think in line with WHO's mandate and mandate of our immunization department, we help to identify what are the diseases out there for which we need to develop vaccines. Then if needed, we facilitate the development. And then once developed, we work with countries to introduce them and then to help them to inform how we could use these potential vaccines. And I think antimicrobial resistance sort of spans across all of these aspects. So if a stakeholder would understand what is the role of a vaccine against antimicrobial resistance, for example, a funding agency, that would help them to decide which vaccines they should invest their money in. If there is a funding agency that specifically is interested in averting the AMR problem, using vaccines as one of the tools, understanding the value would help them to sort of make the decisions as to which vaccines they should be developing. Similarly, for a country or for a region, if they know that they have an AMR problem in the region, they then can look at the available tools to them and say, okay, maybe vaccines could also be one of the tools that we could use to combat antimicrobial resistance. And then also there is a question of how. An example could be if this is just a regional prevalence of antimicrobial resistance, a country or a region would know, okay, here we probably need to put emphasis on a vaccine. In other region, we can continue to use antibiotics that continue to work. So it's really about making decisions about development, making decisions about vaccine introduction and about vaccine use. So having that in mind, we sort of thought, okay, we need to develop some sort of coherent strategy as to how to best do this. And Hanan has alluded to this. So we had published a document that we call an action framework. What it really is sort of guiding principles for us and also for stakeholders outside of WHO to what sort of actions do we really need to take for this understanding and articulation and communication of value of vaccines against AMR to be really understood and well heard. And we decided to strategize our activity around 3 areas. Expansion of licensed vaccines, development of new vaccines that could have potential impact on antimicrobial resistance, and thinking of data generation, facilitating research, and producing estimates that could inform us of the value of vaccines against antimicrobial resistance. And I think in line with the strategy going forward, we have a number of work streams that we are engaging in. We recently, in close collaboration with the AMR department, we want to understand firstly, what are the available vaccines out there. For the WHO has published a list of pathogens for which we urgently need to produce antimicrobials. We call it WHO PPL list. We also want to understand what are the available vaccines for these pathogens. So we are conducting a pipeline analysis to be able firstly to understand what is it that we are working with, what will be the vaccines that will be coming to the market in the next couple of years. Knowing what are the licensed vaccines and what vaccines will be coming to the market in the next couple of years, we want to understand the value. So how could we put a numerical value on a vaccine? And when we talk about the value here, we have a number of criteria in mind. It's not just a version of antimicrobial resistance, but it's all of the things that are secondary to that. When we think of averting the health burden, so if we have a vaccine for Shigella, for example, how many AMR deaths would that vaccine prevent? Or what is the economic burden that would be associated with that pathogen that is resistant to certain strain? And would a vaccine for that pathogen be able to avert a proportion of this economic burden? What will be the antibiotic use that is associated with these pathogens? And again, would a vaccine be able to avert a proportion of this antibiotic use? So we try to come up with some modeling estimates, and we work very closely with collaborators who are also on this call with CDEP, with Joey, closely collaborating with the Gates Foundation, etc., to be able to put this together in a standardized way to inform decisions about vaccine development, introduction, and use. And I think all in all, where we want to go with this to make sure that we are strategic is we want to make sure that we are reaching some sort of impact. So when we think about this value attribution framework, so this understanding of value, when we think about this analysis of what vaccines are available and of the strategy that we have developed, we want to link it to impact. And I think because of that, we work closely with the AMR department at WHO to make sure that our work reaches country level. With Hanan and her team, we are developing national action plans to combat antimicrobial resistance. And us as the immunization folks, we want to make sure that vaccines feature prominently as, yes, they can be one of the tools to prevent antimicrobial resistance. And we want countries to consider that as one of the tools to combat AMR. We're also engaging with Gavi to make sure that, if possible, the work that we are doing in understanding the value would inform their decisions around which vaccines to invest in, to which countries should these vaccines go, taking this AMR perspective into account. So I think all in all, we're looking at loads of different angles. We want to make sure that we're encouraging the use of licensed vaccines by understanding the value. We facilitating generation of data to understand what could be the potential impact of future vaccines that will come to the market. But I think all in all, there is a real need for work in collaboration that would never happen if you would have worked in isolation. So our work is really working closely with the Gates Foundation, with CDEP, with a lot of modeling consortia. We are aiming to inform Gavi in our work. We also understanding that it's not just about human AMR. We're also considering other international organizations such as FAO, such as International Organization for Animal Health. So we work closely in collaboration to hopefully achieve this long-term impact, which is reducing AMR and the burden that is associated with that.
Thank you. Thank you very much, Mateusz. We are moving along well with our questions. For time purposes, I'm going to merge the two questions I had for our next speaker, Deepali Patil, into one, and I think that's going to be okay. So the question for you, Deepali, is how has Gavi incorporated these value of vaccines into its decision-making for supporting new vaccines? And how will the new evidence that is accumulating be influencing your decisions?
Great, thanks, Erta, and thanks everyone at CDEP, and happy anniversary as well. Thanks for this question and hosting this webinar. So I would say Gavi, prior to 2018, I don't think we really thought that much about AMR vis-a-vis our vaccine decisions, largely because I think in the global space, the priority was emerging still for many stakeholders. But in our last vaccine investment strategy, we did include for the first time a specific indicator that we refer to as impact on AMR in our assessment process. And so I think this actually serves as a good signal that we were starting to place more importance on this topic. So let me just take a quick step back because I'm not sure everybody would be familiar with the vaccine investment strategy or with Gavi overall. And so let me just describe that the VIS is a process that we use to determine which new vaccines we add to our portfolio of support. So it is our sort of hallmark vaccine decision-making process. We run it every 5 years. Essentially, it's a comparative assessment. So first we take a scan of the landscape and identify a list of candidate vaccines. And these would be vaccines for diseases which are of high public health priority in Gavi-supported countries, which are low and middle income countries. We then develop an evaluation framework, which consists of a standard set of criteria and indicators, and we use that framework to assess the candidates. And then this allows us to see how the candidates measure up against each other. And in some cases, some of the criteria might allow for some ranking. Usually the criteria that we use, and this has sort of been consistent through VIS cycles, include things like value for money, health impact, economic impact, etc. But as I mentioned in 2018, we included a new indicator on impact on AMR, which we included as part of a larger criterion on global health security. But we really face a challenge on how we measure this indicator. So for many candidate vaccines, even just generally for other indicators, we often have difficulty in getting good basic data on disease burden or economic burden per vaccine and per country. And so you can imagine that at the time, AMR burden was particularly hard to identify as well. And so it's made it hard to do a quantitative assessment. We in the end did a qualitative one where we reached out to key experts in the field and we asked them to rank the candidates in the VIS as well as the current portfolio of vaccines that we supported at the time in terms of what they saw as being the impact on various dimensions of AMR. So this included mortality and morbidity. In fact, the dimensions align quite closely to what Mateusz was just referring to as well in the value attribution frameworks. So it was a valuable and insightful exercise, quite limited by its qualitative nature, which made it quite subjective as well. As conducted, I'm not sure that it lended itself to a sort of make it or break it decision for our process, but I think it really did raise the profile of AMR as an important dimension and then add some important strategic considerations as well for decision making. And then particularly, I think, not just for Gavi, for our decision making, but also for the financing decisions that countries make as well when it comes to introducing vaccines. And so in terms of how new evidence might inform our future decision making, so I think I see two critical shifts here. The first is that it's not actually just new evidence, but it's also an increasing sophistication in the methodology and the ways in which we assess issues like AMR. And so as I mentioned, we face data challenges with our evaluation framework. And in essence, the question that we try to answer in the vaccine investment strategy is really, what is the value of a Gavi investment in any given vaccine, so any of the candidates? And the best way for us to answer that question would be quite directly identifying the impact in the Gavi countries that we support. This requires having baseline data available on burden in those countries. It would then also require having an understanding of AMR dynamics by disease, and then being able to model the impact in Gavi countries, so for our sort of future investment. The second best way would be, an assessment using global burden metrics. This would be less precise for our purposes, but still helpful for a comparative assessment. But you can imagine that it could be confounded a bit by, for example, if the impact is driven by a non-Gavi supported country. And so the third way would then be what I just described that we did in 2018, which is the more sort of subjective assessment. So I think we're in a place where when we get to the next VIS, we would be a lot closer to having that global impact understood. And then in some cases also country and regional levels. I think this would really lend itself to a much more robust indicator, much like Mateusz had already just described. And then the second shift that I see is that the pipeline of vaccines currently includes quite a few diseases where AMR is already being seen as a concern, where these diseases are driving, where AMR is even driving mortality and morbidity for these diseases. So I think when we look at our current portfolio at Gavi, of course, we also see these diseases with high AMR burden, but we didn't really recognize that at the time we made the decision to include those vaccines 5 years ago, 10 years ago, et cetera. But we're seeing it, we already have that sort of forward view. So I think that's really critical. We've already seen TB, Shigella, RSV. Maybe we'll see a vaccine for group A strep sometime soon as well. So I think these are the kinds of things that we're seeing in the pipeline, and that's really important. But I also just wanted to flag that, it's not just investments in new vaccines that matter for Gavi. We also invest in increasing the coverage of the vaccines already in our portfolio. And as I said, many of them are also important for the fight against AMR: pneumococcal vaccines, meningococcal vaccines, Hib vaccines, typhoid vaccines, and even as we've already seen, vaccines for rotavirus and other diseases with a sort of broader set of symptoms that result in unnecessary antibiotic use, like diarrhea and pneumonia. And so I think these are really important. This is a really important consideration as well for us, which is the other types of investments like health system strengthening, immunization program strengthening, investments that increase coverage at sort of the global level, but also at country level, because countries also need to make those investments as well. And so I think in general, a better awareness of how AMR costs lives and money is really important and really helpful for building this case for this greater investment all around. so that we really can make sure that it's all children, all people are being reached with all of the vaccines that we need. So it's not just Gavi decision making, but also I think other donors as well as countries as well. Thanks.
Thank you so much, Deepali. Thank you so much. Now we actually have about 10 minutes to answer some questions from the audience. And I have one over here that perhaps Padmini could address. The question is, could the K-pneumo vaccine potentially be given as prophylaxis for healthcare associated infections when there is invasive surgery or high risk of SSI?
Yeah, that's a great question. So I think the answer is potentially yes. That as others have also pointed out, that gram-negative organisms are an incredibly important etiology that causes significant number of infections, increased duration of hospitalization and deaths among those who are hospitalized for a while, healthcare associated infections across the world, including in low middle income countries, but also in higher income countries. And so a vaccine that targets Klebsiella pneumoniae for neonates, which would be a maternal vaccine given to pregnant women, has the potential to also be applicable in other settings, given in target populations such as those coming in for elective surgery or those being discharged from the hospital to long-term care facilities where there are greater risks of Klebsiella pneumonia related or Klebsiella pneumonia as an etiology for healthcare associated infections. I think the evidence that we need to better understand that is to understand the strains of Klebsiella and the serotypes of Klebsiella that are the causative agents of sepsis in neonates and how well that overlaps with the strains and serotypes that are causing these healthcare associated infections. And that's an area where the foundation, certainly at least in the neonatal sepsis sphere, is helping to generate data. The data that we have thus far suggests that there is a reason to be hopeful that there's a reasonable overlap in serotypes, but it's still a road ahead. And I think one thing I just take this opportunity to add is, in addition to the vaccine development work that we're working on with for Klebsiella, the other area that we're also supporting vaccine development for AMR is through our partnership with CARB-X. So CARB-X is the Combating Antibiotic Resistant Bacteria Biopharmaceutical Accelerator. It's funded jointly by Wellcome Trust, BARDA, Gates Foundation, the German government Department of Research, as well as the UK government. And while CARB-X has a broad ambit, including therapeutics as its mainstay, as well as diagnostics, vaccines do form an important part of the CARB-X portfolio. And in fact, our Gates Foundation support is entirely focused on vaccines. So, and in that sphere, it is not necessarily focused specifically on neonates in the global sphere, even if our interest is there. So I think that there is growing recognition in the product development field as well of the need for support and funding for vaccines for AMR, and a growing, perhaps a small but growing number of companies who are working to develop these products.
Thank you so much. Here we have another question directed to Joe. The question is about the choice of pathogens, talking about E. coli and S. aureus, as both could be very important as they may be way of entry for resistance mechanisms, especially E. coli with respect to ESBL.
That's a good point. I think we would need to know sort of how the overall impact on the burden of resistant disease is changed by any particular vaccine, including one that that could reduce antibiotic use and exposure for commensal organisms that, like you say here, could be harbors of resistance that can be transferred to others, as well as the impact that can be achieved for a more TB-like vaccine, for instance, by just preventing the resistant disease associated with the targeted organism in particular. And so I think this is an exciting area for for exploration for a lot of different pathogens and vaccines.
Thank you. We move on to another question. Perhaps Mateusz could address this one. The question is on how do we work closer with FA and others to approach vaccination for both humans and animals in a One Health perspective?
I think that's a very good question, and this is very much at the forefront of the agenda of WHO and how we are working closely with other organizations. I think we all know that, AMR is not an isolated human problem, and we can only address it if we have a consolidated action between all the different aspects of health. We call it One Health, and to present this, to work in this One Health frame, we have a tripartite agreement between these three organizations. What it means is that we work closely, WHO works closely with International Agency on Animal Health and also the UN Food Agency. And we make sure that when we discuss AMR, we make sure that this is reflected not just in the WHO's mandate, but also in the mandate of these other organizations. That's what's happening at the high level. At a more granular level, I could give you some examples. I know that OIE, which is the International Organization for Animal Health, they also considered how vaccines could prevent AMR in animal world, and they were developing a framework to also prioritize vaccine use for animal world. And I don't want to speak on their behalf, but I remember there was a report that they had issued from a Paris meeting in 2018, where they actually prioritized which vaccines should be developed and used to prevent antimicrobial resistance in animal world. And I think a good example of the impact of this is if we have certain pathogens for which resistance could spread independently of who they infect, whether they infect a human or whether they infect an animal, any sort of reduction of, first of all, the incidence and prevalence, and secondly, the transmission between different hosts actually reduces the chance of developing antimicrobial resistance. So this is why a concerted action between animal health, agriculture and human health is really needed to be able to address that. And OIE and FAO, they all have a lot of input into the work that we are doing. So both into the action framework, they are partners on that. They had reviewed the framework that we had put together, but also in the exercise of estimating the value of vaccines. When we consider the value of vaccines, we presented very much against other considerations such as the context of One Health. So what is happening in the animal world, and also what is happening in agriculture, to be able to really draw this overall picture of One Health and highlight that this is what this One Health approach is really needed to combat AMR.
Thank you. I think we have time for one last question, and this one is for Deepali. And it's on adult vaccines. So how is Gavi thinking about routine adult vaccines that would be needed to address AMR?
Thank you. That's a really good and very timely question as we start rolling out COVID vaccines, which is sort of our first foray into adult vaccination. Gavi's model is primarily set up for childhood vaccination, and until we introduced the HPV vaccine, we hadn't progressed beyond childhood in terms of our support. So I think this is demonstrating how we're shifting towards a more of a life course vaccination kind of approach. I think there's a lot of lessons we're going to learn about adult vaccination through the COVID vaccine lab. So I think the jury's still a little bit out in terms of how we approach this. I think there are probably two aspects that we need to consider, and we would work closely with WHO on this. One is in terms of existing vaccines. There are certain vaccines for which you need boosters, and you would provide boosters through adulthood. And so, is that an area for Gavi support? I think it is something we're thinking about. And then the second area, which I think is being highlighted with COVID, would be flu vaccination and a seasonal approach for flu vaccination, as well as any sort of pandemic preparedness around that. We, in 2018, we did approve what we call a learning agenda, so a sort of targeted investments in looking at how we can support countries to introduce seasonal flu vaccination for healthcare workers. And helping to sort of identify barriers to uptake and feasibility in that sense. So we haven't actually had a chance to roll that learning agenda out yet, largely because of COVID, but looking to leverage some of the COVID vaccination to be able to test that. And then similarly, we have seen in some ways some of the vaccination, some of the outbreak response, for Ebola also includes vaccinating adults. So it's been very piecemeal and very, I'd say, opportunistic for now. But as and when a vaccine comes at us that we need to think about, that is primarily indicated and recommended for adult use, I think these questions around what feasibility look like will come at us. It's probably going to be maternal immunization first, where we have to answer these questions. But we would indeed support these vaccines. So I'm particularly thinking of RSV, maternal immunization, relevant for this context. But we would need to look into the feasibility questions in terms of expanding our portfolio of support.
Thank you. I see that now we are a little bit over time. This has been a great session. I would like to thank the speakers for participating in this discussion, and like many other organizations, including the ones that are present in this webinar, we're trying to bring attention to antimicrobial resistance. And I think that today has been a good day for that. So we would like to thank you for attending. Thank you for taking your time, and also would like to bring to your attention that we have another webinar in this series next month, and that is going to be on the long-term economic consequences of nutrition. So with that, have a great day, and see you next time. Thank you.